So an individual came in to see me the other day with extreme internal rotation. So I deem this as hypermobility in the pelvis. The internal rotation was probably the most internal rotation I've ever seen. And this individual, primary complaint actually was neck and jaw tension. So she thought that her neck, she knew her neck was an issue, but she also thought that her jaw problems had started because of chewing on something hard. I can't remember what it was, but it was kind of an amusing story, so to speak. But I had to explain to her that what she was experiencing in her neck and her jaw was likely a symptom of the hypermobility of her femurs, of her body, which was creating pelvic instability, which then led to obligatory neck breathing, and that is what I'm going to talk about in this video. Our sensory system, our eyes, our ears, our nose, our feet, and even our teeth, and they're huge, set the stage for proper movement. They set the frame for which we then proceed through and into and have the environment flow past us. So sensory precedes motor. So what our brain is sensing and aware of precedes our motor output. So when people are hypermobile or if they have jaw issues, the sensory inputs have been thrown off, and that's what produces then inefficient and strained, patterned, tense muscular output. So what you have to keep in mind is that from the pelvis all the way through the spine and the rib cage, up through the neck to the base of the head. So from the sacrum, all the way up to the occiput, which is the base of the head, it's all one functional unit. So whatever goes on down in the pelvis, or it doesn't go on at the pelvis, will affect how the neck is operating and thus how the head is operating, how the head is able to side bend and rotate. Now, even more importantly for this discussion, this occiput, this is your brain stem. There's a little hole, it's the foramen magnum. The brainstem goes through that. If the occiput, if the head and neck come forward, because the pelvis is tilted forward on both sides and your body has to extend, the base of the occiput may start to tilt back, and that may actually start to kind of impede or kind of block off the space that the brainstem is going through. And that's where all life happens. Heart rate, breathing, all your sensory input is flowing through this region. That's why the importance of the neck cannot be understated. And that's why actually in a lot of my videos, I always say everything comes back to the neck. We need a stable pelvis for a neck to regain its normal curve. So the problem is, once you've lost that normal curve, what could happen? Well, what I just said, all this important function, the vagus nerve, a lot of cranial nerves that flow through this area can get disrupted. But then when it comes to the jaw and the teeth in particular, because this base of the skull, this occiput, where the brainstem goes through, and then the spinal cord, because that occiput is connected to the temporal bones, right? And the temporal bones are the T, right here, they're the caps. The T in the TMJ is the temporal bone, temporal mandibular joint. So when the occiput gets mispositioned for one reason or another, let's say it gets stuck in an up position on the right, which is the normal right TMCC pattern. This is the normal right dominance position. If that gets stuck there for too long, it can start to mess with the function of the temporal bones because it's always stuck. This head has to alternate. This body has to alternate underneath the head. In reality, that's what happens. When we move, our body alternates with rotation and side bending underneath the head. That's what keeps everything relaxed. Once you get stuck in one position for too long, one side of the head will get stuck up, or one side of the skull will get stuck up and the other side down. Normally it's the right side up and the left side down. Mine was different, which is a pathologic condition. Things go worse at that point. So that's why I'm trying to prevent people from progressing into that area. So once you're in this position for too long and the temporal bones start to get thrown off, these temporal bones, which need to wobble just a little bit, there's a little bit of movement to these temporal bones, which allows for chewing, the chewing that humans do, lateral intrusive movements. When that gets thrown off, the jaw can start to drift in one direction or another, and now you lose sense of your mouth. So how do we organize these senses? From a big picture perspective, this is really what postural restoration is about. It's not about the biomechanics. Is there biomechanics involved? Yeah. But is that the issue? No. The issue is patterned biomechanics based off of an asymmetric brain and body that has become a little bit too asymmetric in many cases. And for some people, that asymmetry has become extreme asymmetry. I am an example of this. My whole channel is about this, and I am every video on here, 300 videos or so, I have personal experience with probably all of them. I don't have scoliosis, but I'm not gonna go there, but I've experienced all these things. I was extremely asymmetric, and this canine is my memory. This canine is the memory of how far I've come, because my brain was relying on this canine for positional sense. It was what was holding me up over time, probably because of my left foot, which has a little extra arch to it, and I never really grounded. It's going to be a different video coming up soon. So think about how we are sensorially organized. We have a back and a front, a right and a left. Now, that does not exist in the universe. That is just how humans explain the experience of being a human that moves. Right and left are not out there. That's a figment of the human brain. That's how we categorize things, right? Front, back, right, left. Nonetheless, that's what we have. So with the foot, we have a heel, an arch, and a big toe. We have that on both sides. We also have the outside border and the inside border. We have this for both feet. You need these things for both. You need to sense heel, arch, big toe, outside of the foot, inside of the foot, on both sides for effective shifting from side to side. All right? Then, in the back, we have hamstrings, attachments. Up at the top, right underneath the butt, that proximal hamstring area. That's the area that needs to be sensed big time for appropriate pelvic stability. If you lose appropriate pelvic stability, like someone would when they're hypermobile, you then lose the sense of the ground underneath that heel. So the heel gives that hamstring, that proximal hamstring. So a left heel will give left proximal hamstring. A right heel will give right proximal hamstring. Otherwise, the pelvis will tilt forward as those hamstrings lengthen and start to become unused. Now what happens? Now you got to arch your lower back. And now your lower back stays really, really tight. Your hip flexors stay overactive, and you're just in this extended state. So we have a back and a front. So our back becomes overused, and our front, the abdominals, become stretched out and underused, or they start to actually be used as postural muscles instead of breathing muscles. They have to become breathing muscles first. So if you lose sense of heels, arches, and big toes on one or both sides, you're not going to go through a full cycle. We have to go through full cycles, on, off, up, down, right, left. That gives you a wave. That gives you two. That gives you rhythm. Once you lose something, now you don't really have that rhythm anymore. You don't have the ability to cycle, and that becomes problematic. So if you lose one hamstring because you lost the ground underneath that left heel, you're going to shift, and it's usually the left, you're going to shift over to that right side. That bigger right diaphragm is going to have a big influence. That's going to keep you shifted over to the right side. And now you're not going from side to side very well, so your brain's losing sense of the left. Very normal. That's called the left AIC pattern. It's all very normal stuff. The bigger problem comes when you start to lose alternating senses up in the cranium through the teeth and the visual system. So an easy way of thinking about that would be splitting your mouth into 4 quadrants. You got right molars, right canines, left molars. You should be able to tap each one individually without interference from the other side. You should be able to bring one side. If I'm on my left side, I should be able to bring my left teeth together and not feel anything on the right. I should be able to bring the right side together and not feel anything on the left. I should have a visual system that can look in the distance and up close. Each eye should be able to alternate from far to near. You don't want monovision where you have one eye doing all the work in the distance and one eye looking up close. And I know that is an optometric fix to help people see. It's just not great for the body. So as long as we have these alternating sides and alternating vision, ambient, so peripheral, and focus. It has to alternate. You can't get stuck in one. When you get stuck in one state, your tension levels go way up. So toes, arches, heels. Quads, hamstrings, they have to alternate. Abdominals, sides, right, left, rotation, one shoulder comes forward, the other one goes back. Molar, canine, left, right, far, near. When those senses are all there, you're going to be pretty good. You do PRI programs, they work unbelievably well. But when you've lost sense, which is the story of my life, and which I didn't really have from a very young age, this is why my YouTube channel exists, I know the struggle. This right canine is memento of how far I've come. Because if I ask someone to bring their teeth together, and what's the main tooth or area of their mouth that they feel, I want to hear right molars. I'm okay with left canines. Left molars, I'm like, not the norm. And if you say right canines, it's tough. So I was there. And I wasn't hypermobile, I was just really tight. Now, so hypermobility in and of itself is not always a problem, except when it starts to create so much instability that your neck becomes so overactive that it starts to lead to problematic issues in the cranium. If you find this video interesting, could you like it, share it, comment, or subscribe to the channel? Thank you. So when you see someone with a straight leg raise that is pretty decent, like this one, actually, she could have gone way further than that. Because eventually I did test her myself and it did go further than that. When you see a straight leg raise of that magnitude, they've probably lost proximal, so hamstring stability of their pelvis. They're going to have pelvic instability, which again, once you have an unstable pelvis, your back starts to arch. You lose your diaphragms, your pelvic floor muscles. The pelvic floor diaphragm can no longer pump with the respiratory diaphragm. So the whole diaphragmatic breathing process gets thrown off. And what happens? You become an obligatory neck breather, which pulls your head and your neck forward. So just a couple other pictures to show what I'm talking about here. Here's another, you might start to see knee hyperextension. You see that all the time. Her knees are basically, that's my friend, took it many years ago, but her knees are essentially behind her hips. And she's in a hyperextended, so that's fake stabilization. That is fake stabilization. A lot of people lock out their knees. You should not be locking out your knees like that. You might find someone who can do something like this. I remember this person, she was a cheerleader. And I was just amazed at how flexible she was. So you might see something like that. And then of course, here's the connection between, you may end up being very lower back dominant, like low back extensors, a lot of tension in your lower back, and very hip flexor dominant. Why? Well, because you'll see the diaphragm. Now this is a you can actually find this on YouTube. It's a dissection, but when the person, I don't even know what this person's called, I guess a doctor or some type, is pulling on the psoas muscle, the diaphragm is also moving. So you can actually see, and he says it in the video, that's why I love the video, he says that the psoas and the diaphragm are completely connected. You cannot separate the two. So if you're not using the left diaphragm as a breathing muscle, which is what normally happens when we're in this left AIC pattern, the left diaphragm becomes more of a postural stabilizer. That's why some people will feel tension through the left side of their mid-back. That could very easily be the left diaphragm is being held as a postural stabilizer. We need to get it pumping again as a breathing muscle. But that involves, in order to do that, to diaphragmatically breathe, you also need to have a psoas that relaxes. But in the left AIC pattern, when this pelvis is forward on the left, that left psoas is being held in an overactive position. That's why you need proximal hamstring control of this pelvis again. So it all goes together. You need the hamstrings so that you can inhibit overactivity of the quads and the hip flexors and the psoas, so that the diaphragm can be used as a pump again. So that's just a series of events that occurs. I think I have a couple other, do I have another picture here? You might start to see left lower back muscles get really, really big because the left lower back really starts to end up controlling the left side of the pelvis. So left quad, left hip flexors, left psoas, left lower back, they start to be the muscles that stabilize the left side of the pelvis when you're on that left side, but they're the wrong muscles. You will not be able to diaphragmatically breathe if your left lower back and your left quads and your left hip flexors are the muscles that are stabilizing this pelvis. You need hamstrings, adductors, and glutes on that left side, and left internal obliques at that, which will pull the pelvis back and hold the pelvis in on the left as your weight is shifted on that side. When you have, that's why we were always focusing on left hamstring, left adductor, left glute medius, left internal obliques, to get that to happen. And then when you can do that, you can start to use your diaphragms again, particularly on that left side. But the problem is, if you've become an obligatory neck breather, you have to shut off that neck. Now, it's not necessarily too hard. We do that with PRI techniques all the time. Like, this is a technique where you lie on your back, pick your butt up, pulling your heels down. You should sense your hamstrings. You're feeling your back expand backwards into the floor as you breathe. Hopefully, for a lot of people, that will actually start to relax their neck because they are pulling their pelvis back, sensing their hamstrings, their adductors. Everything is compressing through their pelvis in a good way that offsets the tension that's being created. The pelvic floor muscles start to relax and pump again as breathing muscles with the diaphragms. And then your brain says, that's great, don't need to use this neck anymore. And then you get the curve back in the neck and everything starts to relax and things go very, very well. For hypermobile people, that can be problematic, or that can be more difficult to achieve because of that hypermobility. They're just so unstable. That connection, that brain-body connection just isn't there the way it is on someone who is not hypermobile. But the bigger issue is when that hypermobility and obligatory neck breathing starts to pull that head and neck forward, starts to affect the cranium and the temporal bones, and now jaws start to shift. And you start to get open bites, either in the back or the front. You start to get cross bites, like I had. The canine is kicked out on the right. I had that cross bite. You get that cranium that's locked to one side. And that's when it becomes much more difficult, because you often need a dentist to get some sort of mandibular splint for the bottom to relax the neck, to get your brain to understand where to place your head over your body. And I know that sounds really, really funny, but once your head and neck have been too far forward, that's where your brain is expecting all your movement to occur from. And you have to inhibit that process. So a splint will often give that brain, if they've developed an open bite or some sort of malocclusion or jaw deviation, the splint will help put things back into order sensorially, so the head and neck can go back into a neutral position, and then you can start to actually get your body underneath you again. So hypermobility in and of itself, it makes things more difficult. There's no doubt. It takes longer for people to stabilize than when they're not hypermobile. But the real issue with hypermobility is if that hypermobility starts to create changes in the cranium, and it, like I just explained, how it could happen in the oral cavity and the teeth, but also it could occur in the visual system also, which is pretty complicated, and I'm not even gonna get into it. But so that's the actual difficulty of being hypermobile. It just takes longer. You have to inhibit the neck that your brain has been relying on for so long. The lower back muscles, the hip flexors that your brain has been relying on for so long for breathing and stability, inappropriate breathing and stability, has to be undone and substituted with hamstrings, glutes, adductors that will stabilize your pelvis, that will then allow you to shift from side to side, which is called walking, to provide for rotational activity. A lot of people can't rotate with arching their back or using their neck muscles to help them rotate. We don't want that to happen. You want abdominals to help you rotate, but that requires a stable pelvis first and a sense of groundedness, which all goes away in a lot of people who are hypermobile. Now, what would a compromised breathing system look like? Well, this individual who is hypermobile, who had the straight leg raise of really far, could not blow, you're gonna see, she cannot blow up a balloon in a standing position. Can't get it started. Because her legs are essentially non-existent to her brain. Her straight leg raise is so far that her hamstrings are so stretched out, neurologically just inhibited, that there's nothing stabilizing her pelvis. So she has no diaphragmatic power. However, If you bypass her legs, if you essentially chop off her legs and sit her on a hard box, so her brain is sensing,
and if you round your back a little bit,
her brain is sensing her sit bones on the box, because her hamstrings don't do it for her, she can blow up the balloon without a problem. So that's why hypermobility can be problematic from a breathing standpoint, is that you lose your diaphragms. Sit her on the box so her brain can sense her sit bones where the hamstrings kind of attach. She can blow it up. That's why it's all about sense, it's not about strength. Those hamstrings will come back once she can sense her heels, and she does PRI techniques for her to get back in touch with her hamstrings. But when you lose those diaphragms and you lose pelvic stability, what you often find with these individuals is a lot of neck tension because they become obligatory neck breathers. So what does that look like? Well, here you see a little diagram. The SCM, the two SCMs and the scalenes start to pull the chest up. The SCMs also start to pull the head forward, and then the upper traps start to rotate the head back. And that's how you end up with this head and neck come forward, and then this head rotates back. And now you're in this problematic zone where life, the vagus nerve, and all those ventral vagal nerves, where life happens, communication, your voice, your singing voice, your speaking voice can all be influenced. The amount of people who say, wow, my voice has changed since doing a PRI program, it's not really surprising, because look at the vocal system. Requires a stable pelvis for pelvic floor muscles to function as a diaphragm, to couple with the respiratory diaphragms, to inflate the lungs, to expand the rib cage so the neck and head don't have to come forward, so the larynx can stay in a nice relaxed position. If you have a forward head posture and your neck straightens because you've lost stability of your pelvis and you can now no longer diaphragmatically breathe, so you have to use your neck and it pulls you forward, well, that larynx is going to get, it's not going to be free to vibrate anymore, so your resonation is going to be not as good as it would be. So, and of course, your vagus nerve controls your larynx. So that's the vagus system right there. So if you're a singer, which I am an aspiring singer, I love singing and my voice has gotten a lot better in the past year. I'm hitting high notes like I've never hit before. It's pretty freaking cool. Now my teacher says I have to pick up a guitar. But anyway, that's pretty important stuff. Your vagus nerve, your parasympathetic, your rest and digest system may depend on your voice.